ಮೂರನೇ ಪ್ಯಾರ ಮೂರನೇ ಲೈನು
ತಾಯಿಯೊಬ್ಬಿ Hello, Saramsh. Has she joined?
Hello? Hello?
Hello.
Yes, sir. Not yet, sir.
Oh, I will just call her.
Sir.
She's joining.
Okay, sir. Okay, sir.
Yeah. Did you send
Yes, sir. I had sent her the panelist link also.
others? Yeah.
Yes, sir.
I think
Yes, sir.
joined.
No, sir.
Have the student joined?
Yes, sir. 255 have already joined, sir.
No, what about Dharwad?
Sir. They have also joined, sir. They are joining, sir. They are increasing.
Yeah, you please tell them. It must be more
Yes,
than.
sir. I have told them, sir. Yes, sir. Hello, sir. Dr. Hia is here, sir. She joined. Hello, ma'am.
Hello, can you hear me?
Yes, ma'am. Yes, ma'am.
Good.
Good afternoon. It
Good
must be
morning
late
from
night, morning at your place.
Let me know when I should begin.
Yes, ma'am.
Yes,
Within a
ma'am.
minute, ma'am. Within a minute. Dr. Natwaraj is here. Just waiting for.
Good morning.
Hello, sir, how are you?
It is too early in the morning for you?
Yes, it's 6:30.
Yeah, it is okay there. 6:30 is. So, I welcome, I welcome you. This
Thank
is
you, sir.
Hia Datta.
So should I begin, and do I have share screen?
Just a moment, ma'am. Just a moment.
Sorry.
We will just have a brief introduction and then we can begin.
Okay. Okay, sure. Thank you.
Yeah. Can we begin, sir? Nataraj, sir?
Yeah, please. I welcome Dr. Hia for invitation and taking part in this webinar. You have always been supporting us in all our activities. Thank you very much and welcome to you. Yeah, over to Sanjana.
Sir. Thank you, sir. A very good evening to one and all. I welcome you all to the second session of today's webinar. The resource person we have with us today is Dr. Hia Datta, and the topic that will be addressed in this session is therapy for speech and language disorders in multilingual children. Dr. Hia Datta is an associate professor and undergraduate program director at the Department of Communication Sciences and Disorders at Molloy College, Rockwell Center, New York. Her research interests include finding out how we use our brains to learn language as infants and children, and how we become efficient in this process as adults. Her work focuses on how brain organizes and manages multiple languages, that is, how the bilingual or multilingual brain functions. Recently, her research interests have also included topics such as diversity, equity, and inclusion within culturally and linguistically diverse population and minoritized communities in the world. With this brief note, may I request Dr. Hia Datta to kindly take over and begin the session.
Thank you so much for that fine introduction. I am just going to take a moment to get my slides situated. And I just wanted to check, Sanjana, that how's my audio on the other side?
Yeah, it is good, ma'am. It is audible. It's very good.
Okay, I just want you to know that my speakers have been not functioning 100%, and I receive a kind of a metallic sound. I think it's sort of cutting off at higher intensity. So just in case you say something and I don't understand, that's the reason. But I'm glad to know that on the other side, things are good.
Yes, ma'am.
I wanted to begin by thanking Nataraj sir for giving me this opportunity to talk about something that's very dear to my heart. And I hope we can participate in this conversation together. I feel, although, you know, I'm in US, I live in a, compared to India, a fairly monolingual community. India is such a rich place to explore the questions we're going to talk about today. And I also wanted to say hello to Manjula ma'am. I haven't seen you in a long time, so it's very exciting that you're here. I'm also looking forward to your talk after this. Okay. All right, can you see my screen?
Yes, ma'am.
Okay, I'm gonna make it full slideshow, so hopefully
Yeah,
you'll
ma'am.
see how that goes, okay? All right, and this is good, you can see?
Yes, ma'am. It's good. It's visible.
Okay, thank you. So the topic that I've been invited to speak on is therapy for speech language disorders in bilingual children. And I imagine there is a variety of expertise in the audience about this. I'm sure many know more than I'm going to speak about. So I welcome any questions. I'll try to stop in between to see if you have any. Okay, so this is going to be my outline. Who are multilingual children? Speech and language disorders in multilingual children, current clinical guidelines, current research on speech language therapy, that's what SLT is for multilingual children, and where do we go from here? So I hope you'll be patient with some parts in the beginning if that's very familiar to you, but I thought I require that to kind of set up the stage. Okay, so who are multilingual children is a question that I'm sure in India we know the answer to. But just to sort of set the stage, this is how I think of multilingual children as. These are children growing up with 2 or more languages in their environment such that they use more than one language to interact with the environment in at least some capacity, right? So it's not just that your environment has a variety of languages, but that those languages are being used with the children in some capacity or the other, and also that the children are doing this sort of on a daily fashion, at least using these languages in various contexts. Where are these languages, where is this language exposure happening? It can happen at home and in the environment outside home. That can be any place. It can be in the playground with friends, or it can be at the creche or daycare, can be at regular school, nursery school, and it can be any combination of these things in various capacities. So given that the input of languages vary across these different contexts, children develop multilingually in learning to speak, understand, read, and write different languages, although they are not uniform across these 4 parameters. That is to say, just because a child is multilingual in 3 languages, say Malayalam, Kannada, and English, doesn't mean that that child knows how to speak, understand, read, and write in all 4 languages, and that they do so in equal amounts in each of these languages. Nonetheless, if there's any interaction in substantial quantities and time in any of these, the child, in my view, is considered multilingual. So the other thing about multilingual children is how they learn these languages, and that's crucial. That's really crucial to all clinical processes. And again, this might be repetition, but just to set the stage, there are 2 broad kinds of multilingual exposure in children. One is simultaneous and one is sequential. So simultaneous bilingual language development involves something called bilingual first language acquisition, or BFLA. And here, both languages are learned together in the immediate environment of the child. So this can be very much the situation where one language is spoken at home, and then the child goes to a creche, and that's a different language. And this happens daily from, 3 months of age. Or maybe there are 2 parents and they speak 2 different languages with each other, but also with the child, right? So this is bilingual first language acquisition. So there is not a clear second language there. And in most cases, if this kind of simultaneous use and exposure of these languages continue, then the child becomes an adult who is proficient in all these languages with a native-like capacity or capability rather, right? Only if they're used regularly. Sequential bilingual is then when the child is, the baby, the infant is exposed to one language first, and then after a year, 2 years, 3 years later, a second language comes into the life of the baby. So sequential language multilingual acquisition can happen early or late. So early sequential language exposure is the example I just gave. So say say a family has a child, a baby, and then 2 years later, the family moves from Calcutta to Cochin. And there now the child has access to, the baby has access to Malayalam as well 2 years later. But before this move, that language was not present in the baby's life. So that would be early. And then from then onwards, the family lives in Kerala and the child continues to be exposed in Malayalam, Bengali, and English, right? So that's an early sequential language exposure. Here too, generally, we expect native-like proficiency in all these languages if they're used substantially and regularly. Late language exposure for children is a, I would say, controversial concept, because some researchers think it's anywhere, late languages anywhere after puberty, in accordance with the sensitive period theories or critical period theories. Others think anything after 5 years of age, any language exposure after 5 years of age is already a late sequential exposure. And here, the proficiencies of the language vary depending on the age of the second and third and subsequent language exposures, and also the amount and frequency and nature of language use, just like the other one. So again, how much of these languages are being used in what capacities? So this sort of summarizes how typical children grow in a multilingual environment. So what happens when there are language disorders, speech language disorders in these children? So the main point I want to make in this section, which I'm sure all of you already probably know or agree with, is that the disorders that happen in bilingual or multilingual children, speech or language, are not special, meaning they manifest the disorder is manifested in the languages similarly to monolingual children. So there is not a special circumstance via which we're going to detect disorders in multilingual children. And that's an important clinical concept to have. It's an important concept for education, for public education, because families might think, oh, it's okay that my child is 3 and speaks a few words because, oh, she is exposed to 4 languages. But that's not true. So just as a reminder, monolingual children attain several communicative milestones roughly in the same timeline as multilingual children, same timeline as monolingual children. And this is both for pre-linguistic and linguistic domains. So the pre-linguistic milestones starting from birth include vocal, speech, cognitive, and social. Milestones such as cooing or reduplicated babbling. Cognitively, they start pointing, and then, joint attention. So all these things should come in at the same time, whether the baby is being exposed to 1 or 5 languages. Linguistically, you start seeing patterns 6 to 8 months of age. There's a vast literature on how multilingual children develop specifically, starting at this time, but sort of from the clinical perspective, around 6 to 8 months of age, the baby should start understanding one's name and several other single words. Comprehension comes in. And in terms of expression, first words do appear around the same time as monolingual children, perhaps a month. Some studies show maybe a month delay, so maybe around 13 months or 14 even, but nothing substantial that should stand in the way of a multilingual child expressing one's first words around 1 year of age. And then the subsequent phases of general development follow the monolingual timeline, meaning you should see the single words sort of increasing vastly, 2-3 word phrases coming in, sentences. And if there has been substantial and consistent input in 2 languages or 3 languages, then you should expect all of these expressive and comprehensive vocabulary and sentences to be in all those languages. And I'm sure that this is not news to you, that if you compare each of those languages with monolingual norms, they might fall short. But together, if a baby is exposed to, say, Hindi and English, together they are able to, the baby should be able to produce substantial numbers of words and sentences in Hindi and others in English as the age progresses. And in terms of speech, we should expect the child to be intelligible by 4 years of age to unfamiliar conversation partners. So in terms of the question, how early can speech language disorders be detected in multilingual children? The answer is anytime you see a lack of some of these milestones. Sorry, I'm just looking at the chat to see if anyone asked anything. Now, differences will arise, like I said, from the amount and frequency of language input in each of the languages. So the amount of output in each language will vary from monolingual norms, but overall, we shouldn't see any differences. Some red flags that we can sort of reliably identify is failure to, like I said, achieve any of those communicative milestones, particularly the pre-linguistic ones, because that absolutely has, no significant language differences from, at least from a clinical standpoint. But anything like fewer than 10 to 20 meaningful words by 18 to 20 months, fewer than 30 to 50 words by 24 months of age, and failure to combine words by 24 months of age. Here you see a very old study, a graph from a very old study. These are words, produced over time for bilingual children. And you can see by the time they are of 30 months of age, they have many words, even in average, as well as in 10th and 90th percentile. So these red flags are very important for clinicians to know, of course, but also for clinicians and doctors to communicate to parents. And by parents, I mean all parents in urban India, because most of urban India have multilingual exposure, right? I think that one of the things I have witnessed here in the US amongst communities is the reluctance to go to a speech language pathologist in case of any suspicion of impaired speech language development, because parents think it's a discredit if their child is labeled. And I understand the sentiment. I imagine that the same sentiment is present in various communities internationally. But I have to say 2 things about this particular challenge. One is that the earlier we detect any of these problems, the better chance the child has to a more typical integration, particularly in cases of say primary language impairment, or what's known as specific language impairment. or speech sound disorders, right? So having detected some of these problems as early as 18 months can make way for a much more socially integrated development for these children. Having a label sometimes is not a permanent thing. and having labels also helps people become aware of what these difficulties are. So for example, having a specific language impairment or a primary language impairment where a child possibly gets therapy outside school is not the same as is not the same as children who have significant language disorders following intellectual disability and are in different schools. So I'm not saying one is better than the other, but what I'm saying is having children identified as different disorders as early as possible gives the public an understanding of what these problems are and how they can be managed. So in terms of speech, we again are looking for unintelligible speech in first language or all languages, depending on language input. And then as you can see, by 4 years of age, these kids should be completely intelligible to strangers. So this is a handout I found from, I think, Asha, where the authors have listed some myths and some facts about bilingual children and bilingual development. I won't go through the entire thing, but I'll just focus on this one with the blue line here that says bilingual children should not mix parts of the languages they speak. So some families might think, particularly if they're sequential bilinguals, that it's very odd or it's a sign of a disorder if their children are quote unquote mixing languages. But again, this community probably already knows that there are rules to mixing languages, and indeed being able to do so within a rule-bound context for children as young as even 3 years of age shows mastery of these languages, not a disorder. So again, these are things that clinicians should consistently be aware of and provide consistent messaging to families and communities. Okay, so what does language disorder in a multilingual child look like? So here, this is a old case study from Hom and Dodd in 1999 about actually a child who speaks Punjabi and English. So I'll just read some portions out. So HK was referred to the study by a speech language pathologist who had assessed him at school. And HK's parent has been concerned about his speech development since he was 2, but they had not sought advice regarding his speech because he was primarily exposed to Punjabi at home, and they did not think an English-speaking speech language pathologist would be helpful. So see, already you can see some impact of the family being bilingual, and because they are bilingual, they're reasoning the whole situation in a way that they wouldn't have if they had only one language. So he was born 4 weeks premature, but there were no medical complications. Parents were fluent speakers of Punjabi and English, and at the time of the study, Punjabi and English were spoken at home in approximately equal amounts. So the clinical problem with this child around 4 years, 6 months of age was that he was severely unintelligible, that he was nobody could understand him very well. So here's the initial assessment and baseline data for this child. So percent consonant correct, which is PCC, in Punjabi was 57.7, and in English was 44.9%. So you see, the key thing I want to highlight here is what I said in the beginning of this section, that the disorder does manifest comparably in all the languages the child speaks, particularly in the dominant language. And in a lot of cases, that language, particularly in India, perhaps is the first language or the home language. The child also had inconsistencies that you see here. And here are some of the error patterns that the child showed in terms of phonological processes. And we'll talk about some of this later. So let's move on to current clinical guidelines. Now, I'm going to say it right now, and kind of like, which is an anticlimax perhaps, but there are more guidelines for assessment than for therapy. Really, there's very, very, very little about therapy, which is why I enjoyed putting this presentation together, because I think there has to be a start as to, where we go from here. So these are some current assessment recommendation in how to perform a comprehensive assessment for a multilingual child with a multicultural history. The first piece is getting a detailed cultural and linguistic case history. We assess in all languages. What do standardized tests do for us? There's cognitive assessment. We can resort to dynamic assessment, Criterion reference tests, and different things for speech and language. So let's go into it in a little bit of detail. So I still remember taking case history when I was a student at Aish. We know that this is a very important part of how we gather information about our patients. But given that majority of our clients in India or internationally are multilingual, there has to be a special section dedicated on how many of these languages these children speak, but not only just the number of languages and what languages they are, but what are the contexts of exposure? How often does the child use these languages? How are they acquired? Is one language only happening in school and the other at home? What settings, and how much of these languages are these children using? We really need very detailed data on these different things that are listed here, because unless we have this data, we cannot develop a good intervention plan for these children. And then along with that, we also have to get to know the family's cultural practices and values. And this is a particular point I want to make. And we do this to avoid all sorts of assumptions and bias, no matter we share our quote unquote culture and language with the client or not. So, as a Bengali person, of course, I had the experience of interacting with many Kannada speaking patients when I was at Aish. And I really knew almost nothing about the cultural values and life in Karnataka, in Mysore. So it really helps if you kind of get to know this by establishing a rapport with the patient. But then it is also important for me to do this if I am, say, practicing in Calcutta somewhere, where it's the city I grew up in. I speak the language. I speak 3 languages that are spoken in Calcutta, but doesn't mean that I know my client's family. So establishing this sort of rapport where your client can trust you, even though you are a stranger in all capacities, will establish means for you to have goals for your clients which are valued by the parents. And that's important because you have to involve the parents in intervention. So assessment in all languages is a must, particularly in the dominant language or the first language or the native language. Sometimes that may not be, sometimes the dominant language may not be the first language, depending on when in the child's life you are doing this assessment. So if this is a person who is who moved from, say, Chennai to Delhi when she was 2, and really her Tamil treated at home, she wanted to only speak Hindi and English, and you are assessing this child in class 2. Her dominant language may not be Tamil anymore, so be aware of that. In terms of standardized tests, these are not very effective unless they're normed in the same population as the patient, meaning that their cultural, linguistic, and dialectal and socioeconomic makeup are the same. And that really then limits these tests to ones that are actually developed in those communities. I know that there are several tests that are translated and perhaps even standardized, but again, it's important as clinicians to look at the norm group. Are the norm groups, monolingual Kannada patients, or are they bilingual Kannada patients, Kannada and Hindi? Or is it that these are urban children who only speak Kannada and English that this test was normed on? So all those are important aspects. It's important to resort to cognitive and non-linguistic assessments, such as language processing tasks, like working memory, non-word repetition, phonological discrimination, because these tests rely less on the language, and you can get to the more foundational processes for language, which are important in terms of learning language, which is what we're trying to fix. 2 things to mention in terms of assessment are dynamic assessment and criterion reference tests. So dynamic assessment is a very appropriate tool for patients for whom we cannot find tests, particularly in languages that there are no tests developed in. Because what dynamic assessment really focuses on is how stimulable the client is. If you teach your 5-year-old child 10 words in a half-an-hour session in any language, whether it's in the child's stronger language or the non-dominant language, how quickly does the child learn? Because if the child is not someone who has a language disorder, the child will learn quickly. Similarly with speech. So if the difference in intelligibility has to do with the fact that the child has a heavy accent in the newly acquired language, that can be remedied quickly through a dynamic assessment procedure. So say, for example, a lot of North Indian languages don't have retroflex L's, for example. And if that's a sound that seems to be substituted in your speech sound disorder child who is, say, 6 years of age, you try to stimulate that child using that sound in word initial position, say for 10 words, and see, does the child learn? Can the child even establish that sound through your direct training, right? So that's a very useful process. And then also criterion reference tests where you're not relying on norms, but relying on some kind of predetermined criterion that you establish for your client group, such as I'm going to see if the child is able to converse in their dominant language, at least. So when it comes to speech, please remember that oromotor assessment is an integral part of doing a speech sound disorder assessment, because again, not every disorder that manifests in speech for multilingual children has to do with the languages themselves, but it could be some kind of motor speech disorder. And again, that should manifest similarly substantially in the various language the child speaks. When it comes to language, of course, you're doing an assessment of a variety of things such as morphosyntax, syntax, vocabulary, sense production, word production, and comprehension, both in comprehension and expression. And then the last thing I want to mention is a speech or a language sample is a powerful tool. And there is much to be analyzed from that in quantitative data, in quantitative evidence. And that can very nicely complement any of the other tests that you've done. It's naturalistic, and there are plenty of tools available for doing these kinds of analyses from both speech and language samples. Does anyone have any questions? Okay.
Ma'am, I think you can continue. We can address the question at the end of the session.
Okay. So going back to the example of HK, that the HK who spoke Punjabi and English and is 4 years, 6 months of age, these were the assessments that were conducted. A Rockdale assessment of Mirpuri phonology, which is the Punjabi version of that, the Goldman-Fristow test of articulation, 25 word test for inconsistency. So, and a contrastive analysis of Punjabi and English using speech samples. So what is a contrastive analysis of languages? That's one of the first things you want to do when you have a child who speaks multiple languages, whether or not we share the same languages with the child. So if I had to assess a child who speaks, say, Bengali and Hindi, or Bengali and English, let's say Bengali and English, because those are my dominant languages, I would still need to do a contrastive analysis of what sounds Bengali has or what morphosyntactic rules Bengali has, and compare it to English just to know what kind of output I expect from this child, given the typical scenario, right? So here's a phonological grid for Punjabi. And if you look at the sounds I've circled, these are sounds that are not present in English. At least I may have missed some, but these are definitely not present. And I don't know Punjabi, so I'm not going to attempt to produce this. So going back to the child's data that I showed you earlier, the other thing to do, once you kind of know the sounds in the two languages, is to see what kind of patterns the child shows in both languages. Now, sorry, I have to make one more point from this previous slide. So out of all these sounds, you see that I've only highlighted, or circled rather, 4 sounds, right? So that means a ton of sounds here are overlapping. So I've highlighted sounds that are present in Punjabi and not in English. I realize I missed the dental sounds. So a few more maybe, but majority of these sounds are present in English as well. So then you expect when two languages share a substantial number of sounds, you do expect the disorder to manifest in both these languages. And if you go back and look at the data, you will see that that is true, that for both Punjabi and English, HK has, at chance, person consonant correct or thereabouts. And if you look at the phonological processes present in this child, you will see that there are these ones that I've highlighted, those overlap between Punjabi and English, like cluster reduction, stopping, backing, devoicing, and aspiration. So the next step is to know, at what age these phonological processes should have disappeared. And I tried looking for many different phonological process elimination charts. That was not too overwhelming. This is not an exhaustive list, so it doesn't give you all of this, but just to point out a few, excuse me, that stopping is something that we expect mostly at 3, but there's some stopping happening for this child who's 4.5 years old. Cluster reduction also, a lot at 3, not so much after 4, although there's some that happen after 4, and this child has cluster reduction in both languages. Backing is not up here, but backing is considered an atypical phonological process, particularly if it continues up until, to 4 and 5 years of age. And then weak syllable deletion, also something that sort of should wrap up in before 4, something that's present here in the form of initial and final consonant deletion. Sorry, I misspoke. So weak syllable deletion is something that should disappear, is not here, but instead the child has initial consonant, final consonant deletion, which is not listed here. But again, these are things that should kind of disappear early on in age. So having, done this, you can see that when you compare the dominant language, perhaps Punjabi here, but the child speaks considerable amount of English too, that the disorder has manifested in both languages, which means it's not a matter of English being a second language for this child in any way, that it is a disorder and the child needs therapy. Here's a summary of what is happening. The child produces more anterior sounds than posterior sounds. The sounds are substituted within the same sound groups. Stops are most frequent. The child has atypical phonological processes as well as inconsistent production of target sound. And the person consonant correct are comparable in both language. So in terms of therapy, really, there is almost nothing from any professional organizations here in the US, at least. So ASHA says, according to Code of Ethics, as SLPs are obligated to provide culturally and linguistically appropriate services in all different domains, including treatment. Sorry, that's what I had highlighted here, treatment, but it kind of jumped up. So we have to do that no matter what the clinician's language is. So we have to determine what's best for the client, depending on the clinician's language and dialectal proficiencies and clinical skills in these language and dialects. We are to provide multilingual therapy for these children. And if we cannot do that, we are advised to use professional interpreters, right? So not family members, not other staff members in the clinic or the hospital, but as much as possible, professional interpreters. So at this point, given that this is the situation, what do we need to know about therapy? So these are the 3 main questions that I have highlighted in terms of what are crucial information that's lacking from clinical guidelines. Does therapy in 1 or more languages have negative communicative outcomes for children with speech language disorders? And if not, which languages do we provide therapy in? First language, dominant language, all of the languages, environmental language? How is multilingual therapy carried out in practice? So, all right, we can do multilingual therapy, right? That's say we find out that's the way to go. I would say number 3 is where we are stumped. There is very little information on how multilingual therapy is carried out in practice. There's none in the US. I can tell you that. I don't know how much evidence has been gathered internationally, but we really need to document that and have some kind of systematic approach to these questions. So in terms of the first question, does therapy in more than 1 language have negative communicative outcomes for children with speech and language disorder? The current evidence says no. Compared to assessment, compared to nature of language development in bilingual children, this, please don't get me wrong, this research is very limited, but it's consistent. It's consistent in that this research documents that bilingual children with language or speech disorders do not perform any worse than monolingual children in their respective languages or communicative outcomes. And there are a lot of studies, again, not a lot of studies, but substantial number of studies now that document this in a variety of speech and language disorders, phonological disorders, ASD, Down syndrome with intellectual disability, and expressive language disorder, primary language impairment in a variety of languages. And then also, when input and consistency of input in all the languages are more or less comparable, the child usually manifests the disorder in all of the languages comparably as well, right? Remember, again, the input is a key factor, right? So given this, there is no reason to think that if a child has ASD, providing bilingual services, bilingual therapy in, say, Tamil and Kannada to this child will harm the child. There is no evidence that says that. So say we are good with that. We are ready to provide bilingual therapy. The question then becomes, which language or languages do we provide therapy in? Now, to address that question, I have three other questions. The first one is, why is it important for multilingual children with speech language disorders to be able to communicate in more than one language? The second question is therapy in one language enough to improve all other languages of multilingual children with speech language disorders? And if one language, which language, right? Which of, not which language, English, Kannada, Hindi, but which of the child's languages? And then, does multilingual therapy show any benefits? So to address the first question, why is it important for multilingual children to grow up in a multilingual environment? Well, the same reason it is for the typical children, right? We are part of multilingual families, multicultural society. To be able to communicate in all the languages of the society means we can access the culture in all these languages. My son is 6 now, and in where I live, there is no one else who speaks Bengali other than me and my family. And I think my son is predominantly, I would classify him almost monolingual. He does understand a little bit of Bengali, say 10%, but he really has no access to the wonderful world of literature and arts that my other languages provide me. So why shouldn't children who have language disorders have access to that? Why should we stop at saying, oh, my child wasn't really expressing at all? Now that the child is able to express in one language, let's just be happy with that. We can do more. And of course, there's a goal in preserving languages and dialects across generations, and families want that. So the other thing to sort of address is, all right, let's see if providing therapy in one language is enough to improve the other languages, right? So the current research does say yes, there is limited efficacy evidence for that. Therapy in one language does improve the non-target language, but this happens more when you address the more cognitive, abstract aspects of language, one, and also when there's substantial overlap probably in the languages, right? So I don't know about Kannada therapy improving English and so on and so forth, say in terms of language. But if the child needs therapy in producing, say, bilabials in Kannada, and gets therapy in that, will the child be able to produce bilabial sounds in English? Yes, that will generalize, right? And then language transfer occurs more from the dominant language to the weaker language more reliably, which means often that's the first language of the child, particularly in a sequential bilingual situation, right? So again, if possible, if the client and the clinician share that language, that is a starting point, if not bilingual therapy. And if not L1, then the more proficient and currently used language, which is something I talked about earlier, depending on the child's language profile. And finally, does multilingual therapy show any benefits? Yes. Two things to say about this. Not all components of language and speech can generalize from therapy in one language, even the dominant language, to others, due to, like I said, structural differences between the language and contextual use of different languages, right? So it's important to provide multilingual therapy where it's possible, whenever it's possible. So I see there is a question, but I'm not able to see it for some reason. But I'll get to it. And the second thing is there's increasing, although limited, evidence for multilingual therapy for speech and language disorders, in phonological disorders, in primary language impairment, in autism spectrum disorders. For a variety of disorders, there is about, I would say, easily, anywhere from 15 to 20 studies which show that providing bilingual therapy definitely improves both languages beyond what it can do if you provide just one therapy in one language. The caveat is that if you're a clinician who is serving a Tamil English client, I don't know if there's one study for you, because I'm talking about these studies internationally. And there are studies in Indian languages. In fact, there was a very recent publication by Sendilnathan and Chengappa in 2019 that worked with, so this was this person's PhD dissertation, and it was nicely shown that children with ASD do benefit from bilingual therapy. So if you're in doubt that, it doesn't harm, but does it benefit? It definitely does. But of course, there has to be rigor in how you provide it. So there are, particularly for sequential-ish, late-ish bilingual children, like children who learned language, say, after 6 or after 10, or not actually, although the paper that I'm reporting this from suggests this for sequential bilingual children, talk about a bilingual approach. And there are two kinds of bilingual approaches that is reported here. One is where both languages are directly supported, meaning you provide therapy for both languages, but in different ways. The first one is where you are encouraging the parents to maintain the heritage language at home, but the speech language therapist works directly on academic and social language. So both languages directly supported, but therapy is provided in the first type of bilingual approach for the academic or social language, the language of the school. But it's important to maintain the heritage language. And the other way to do it is to provide therapy actually in both languages. This is, of course, where the speech language therapist shares the languages of the client. Now, actually, moving on to the other approach, which is a cross-linguistic approach, here, instead of working on the languages overall, just specific errors in each of the languages are addressed separately. So, for example, one day, in one session, the therapist addresses, say, plural use in Kannada, and another session, the child is working on tense in English, right? So separate sessions for separate deficits or targeted deficits in each of the languages. Now, in both situations, again, there is no real data on how these languages are being dispensed in the sessions. So in the cross-linguistic approach, the suggestion is one session, one language. But this is not by any means a standard, or it's not something that has been researched, or there's no evidence as to whether this is the best way to do it. So on that note, here's a study from 2008 where this person looked at a number of speech language pathologists providing therapy across the world. And you can see India is listed here. 13 therapists answered from India. And then here are the languages represented: Kannada, Marathi, English, Malayalam, Tulu, Tamil, Bengali, Urdu, Hindi, French, Japanese, and Telugu. So these therapists were asked different questions about how they are providing therapy, bilingual or monolingual. So here are some interesting data. It is more than 10 years ago, but I don't know that the numbers are very different. So figure 1 shows you how many monolingual and bilingual therapists overall, not just from India, answered. So there were 73 monolingual therapists and 25 bilingual therapists. The next piece then is how much bilingual intervention was provided. And because you see there's such a difference in monolingual and bilingual therapists, only 13% of the clinicians who answered said they were actually providing bilingual intervention. This pie chart shows you how often these therapists more than 10 years ago were advising their bilingual clients to support both languages. You can see 74% of these clinicians were asking families only to speak one language. So here are some rationales that are provided for choice of language intervention. So you see language of difficulty, language of the community, which seems to be a popular choice, school language, another popular choice, language of the therapist, that's 10, and then 5 say there were no other alternatives, right? So of these people who are providing bilingual intervention, how are they doing it? Some used 2 languages simultaneously. This is exactly how Jordan writes it, and others, they would start in one language and then switch over to another language. So sort of wrapping up this section, how is multilingual therapy carried out? This spring, one of my undergraduate students, Melanie Baracco, surveyed, did an online survey of bilingual and monolingual SLPs here in the US. And she got an N of 27, and of these were N of 27 who responded, and 65% said, and change said, they mixed language and dialects throughout the session. 26.9% said they never treated 2 languages or dialects with their bilingual children, and 7.7% said they blocked times, meaning say they do 15 minutes of English and say 15 minutes of Spanish. She also, so that's was an important finding in terms of what clinicians are actually doing, given that there are not any real guidelines. So I see it's 7:31. I did have a case history. I'll just take 2 minutes to talk about where do we go from here. So we all know about evidence-based practice, and multilingual children are a very good case for using that. Just a reminder, what is evidence-based practice? We ask, we assess, we appraise, apply, and then reassess our choice. So we have to ask questions about the clinical situation. And I will leave you with the first piece, which is what kind of questions are we going to ask to gather internal and external evidence for our specific clients. So in terms of providing services to multilingual children, we can actually, instead of one question for our client, we can ask two. And the two questions are these. Number one, in general, is there evidence available to support the use of both languages for intervention of language impairments in bilingual learners, speech or language impairments? But the other thing that sort of comes with the territory here is more specifically, what evidence is available for increasing comprehension and expanded utterances, meaning your particular client's target behaviors for bilingual children with language impairments. So you want to ask a general question about whether bilingual intervention is supported or not. And I hope that I've convinced you in this talk that it is, that we can approach a bilingual client or a multilingual client with a multilingual intervention. And there is evidence that currently supports that. But what you need to look through is what the family wants, what the child is capable of, what the language history and the cultural history of the child is, what your expertise are, and what the literature says, if anything, about your specific client's linguistic combinations and speech or language target behavior that you have set out to improve, right? So, and then you can engage in the EBP process as you would. So you assess by gathering internal and external evidence for both of these questions, and you make a decision depending on where the heavier evidence lies. You apply the intervention in 1 or 2 or 3 languages, depending on what you find. And then you reassess after 8 to 10 sessions. What are the outcomes? Do you continue this approach? Are you going to give therapy in blocked 15 minutes of one language and 15 minutes of another language? And has that helped? Have you gotten parents involved? Has that helped? Or are you going to start a new approach? So I'm going to stop here and say thank you. I see there are 2 questions. I'm going to stop my share to see if I can see them.
Thank you, ma'am. You explicitly highlighted the current clinical guidelines for assessment and therapy for speech and language disorders in multilingual children, and the research evidences that you provided were extremely helpful to understand how multilingual therapy is practiced. Thank you very much.
Thank you. I see 2 questions.
Yes, ma'am. The participants have posted 2 questions. Can we take it up, ma'am?
Sure, absolutely. Do you want to read out the question? Do you want?
Yeah, I will.
Go ahead.
Yeah, the first question is, we are introducing language. If we are introducing language 1 initially, then at what age can we start giving training for language 2?
Okay, so first of all, great questions. I love them. Thank you so much. So Samprita, I would say it depends on the child's, both the child's clinical profile and linguistic profile, right? So I'll maybe offer 2 different solutions. So say this is a 5-year-old child who moved from Delhi to Mysore 1 year ago. Parents speak really English and Hindi mostly, not really Kannada, but the child started school and, you know, there's Kannada is part of the school curriculum, and the child has language impairment. So if so the child hasn't really started learning Kannada very much anyways, as well as there's a language impairment that is manifesting itself both in Hindi and Kannada. This is a good case to, I would say, if you look in the literature, to maybe start with Hindi. And then you have to, like I said, assess and reassess every so often to see how this child's Kannada is advancing. So say you have the child for 1 year, 6 months later, you see that the child has, is able to produce at least phrases in Kannada. That would be, I'm sorry, in English. No, in Kannada. Child is producing phrases in Kannada. So I meant you start in Hindi. And if the child is able to produce some phrases in Kannada, you can provide therapy in Kannada at that time. So that is one scenario. But if this is a child who has been exposed to Kannada from 2 years of age, and you are meeting the child when the child is 10, then you could start providing Kannada therapy as soon as the family and the child is comfortable doing it. So that's, I don't know if that was a clear enough answer, but again, going back to using your EBP to make a decision. Okay, Amulya, will you read the second question?
Yes, Amulya Roberts has asked, if a child is equally exposed to 2 different languages, which language has to be majorly focused in rehabilitation?
So this is, again, without any other information, I would say this, if there's equal exposure and use, then I would go with a multilingual or a bilingual therapy situation if the clinician is able to do so. And the parents are on board with it. There's no reason not to do that unless the clinician doesn't speak one of the languages, or the child doesn't really use the other language. As long as the child is using both of these languages, the child is equally exposed to, I would say, bilingual therapy here. Thank you, Amelia.
Yeah. Will multilingual therapy cause confusion in children? Is the next question.
So thank you so much for that question, because what I have gathered by doing, literally by getting this presentation ready, and I had so much fun doing so, is that current evidence says, no, it doesn't. It doesn't cause confusion in children. Now, you might say, oh, so we can do it any which way. Maybe not. So depending on, again, the child's language level or speech level, you want to have some organization of how you provide therapy, bilingual therapy. So do you remember we talked about we could do this simultaneously, meaning you can use both the languages alternately within a session. So for example, if I talk to you, in English, and then I switch to Bengali, or ami eram kore kotha boli, thik ache tarpore we can, talk to the parents in, another language. Is that maybe not the best way for the child? Maybe it is better to have blocked practice, given that you're beginning to establish a rapport, or maybe the child is used to hearing, Hindi and English at home all the time. In that case, you can mirror that, and that will be fine, is what the literature currently says. Thank you.
Yes, ma'am. Next question is related to therapy for stuttering, ma'am. They have asked, in children with stuttering, which language we have to provide speech therapy? The one with more disfluency or the one with less disfluency?
This is a very cool question. Thank you so much for it. I didn't look into the stuttering literature. I did see, though, that there's substantial bilingual stuttering literature coming from India, which is wonderful. So again, going back to EBP, I would say look at what the evidence says about stuttering in children and how bilingual therapy has fared. And another thing maybe to consider, whether starting in the language with more disfluency such that your techniques are making a substantial impact on that language will motivate the client, more, and therefore create confidence and make for a better therapeutic approach. That would be one thing. The other thing to kind of also, the other thing to think about also, of course, is whether how the language proficiencies are in these languages. So here again, if the child is not confident in one of the languages, and that stuttering does have a psycho-emotional overlay, maybe that's not a good language to start with there, right? So here I would start with the dominant language for the child, get some of the disfluencies in control, and that gives the child sort of an opening to work on the other language, which is weaker. The third thing is, if stuttering is not so, again, please know that stuttering is not at all my area of expertise at all. But if it is the speech or, the speech motor aspect of stuttering that's at play here, then addressing the disfluencies in the dominant language could transfer to the non-dominant language as well. So again, another case for perhaps starting with the dominant language. Thank you.
Thank you, ma'am. Ma'am, I think due to time constraints, can we please mail the remaining 2 questions to you, ma'am? Would it be possible for you to answer them?
Yes, absolutely.
Yes.
There's another
There's
one.
another one. Yes, ma'am.
Would you mind emailing them to me, and then I will.
Ma'am. Sure, ma'am. I will email the questions to you.
Thank you.
Okay, ma'am. Yeah, ma'am. On behalf of JSS Institute of Speech and Hearing, I request you to kindly accept the token of appreciation, ma'am, for being the resource person for today's webinar.
Thank you. Can
Thank
I
you.
request? Sorry, can I
Thank you,
request
Dr.
one
Hiya.
more thing, Sanjana?
Yes, ma'am.
Could
Sure,
you-
ma'am.
Could you send me all the questions, even the ones I answered?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Thank you so much. Sorry, sir, I interrupted.
Dr. Hiya, thank you. Thank you very much for sparing your time, that too early morning, disturbing your regular activities. Are you hearing me?
Yes, sir.
Yes.
You are audible, sir.
Yeah. Thank you. Thank you very much.
Thank you, sir,
Of
for the
course,
opportunity.
you have stimulated many young brains, I believe. At least you have made me to think more about the possibilities of carrying out studies in this area, because India is a very fertile land for research.
Oh, absolutely, sir. I mean, that's the norm.
I look forward for the collaboration with you, and we hope we'll be able to continue to work together. Thank you very much for spending your time and taking part in this webinar. Thank you.
Thank you.
Before starting the next session,
Yes, sir. Nataraj, sir.
announcement.
Yes, sir.
Sad thing that I have to say. One of our friend and professional colleague, Mrs. Mudvalli, passed away today morning. She was a student of Aish from 68 to 73, and she has served at S.R. Chandrasekhar Institute of Speech and Hearing, Bangalore, and also in Samvad Institute. She was a very fine professional and good friend of many of us, and the loss is really regretted. I mean, we convey our condolences to the family of Mrs. Kumudvalli. Thank you.
Yes, sir.
I take this opportunity to welcome Dr. Manjula. You're welcome. Thank you for
Good evening, sir.
accepting our invitation and taking part in this webinar.
Good evening, sir. And I hope my voice is heard. I have an old laptop, so I'm not so sure whether I'm audible clearly.
Yes, yes, ma'am.
Yeah,
You're clearly
you're
audible.
Okay.
Now you are audible.
Just hearing the news from Dr. Natraj, it's a little depressing to start off my speech here. Yes, Kumudwali was my friend too, and yes, I'm shocked to hear this. And she was my super senior, and of course, as a super senior, we kept meeting, and at each we had very good interactions. And yes, it's not so nice after hearing this news to speak in this talk, but things have to happen. Things have to move on. So with that, first of all, sir, Dr. Nasraj and the team in JSS-ish, I would like to congratulate them for celebrating this 20th anniversary in a very, very meaningful way. And thank you for giving me this opportunity to speak on a topic which I've thought for some time and I've practiced as a clinician too. And my special greetings to Hia. Hia, it's so nice to see you and hear your voice and talk for so many years. All the scenes in New York when we went to you, Sayukta, myself, and Swapna, all were coming back as flashes of memory. Nice to hear you, Hia. God bless you. Take care of yourself. Okay. For that note, I'll just open the slides. Just give me
2 minutes, ma'am.
Yeah.
So, we will now begin the session 3 of today's webinar. We have Dr. R. Manjula with us today, who will be speaking on the topic Augmentative Strategies in Aided Communication. Dr. R. Manjula has guided 8 PhD candidates so far. She has guided 55 master dissertation students. She has been instrumental in carrying out 3 extramural and 10 in-house projects. She has several book chapters edited at both the international as well as national level. She has papers published in several national as well as international journals to her credit. She has several papers published in proceedings of various seminars and conferences too. She has been a member of the editorial board for several journals. She has served as a peer reviewer for 4 journals. She is a recipient of several awards, including a Dr. Ratna Oration Award, which was given at the 45th Convention of the Indian Speech and Hearing Association. She was awarded the WHO Fellowship at University of Florida, USA in 2000. She has won more than 21 Best Paper Awards for scientific paper presentations. She is a member of the International Society on Alternate and Augmentative Communication. With this brief note, may I now request Dr. R. Manjula to kindly take over the session.
Thank you, Sanjana.
Yes, ma'am.
I am overwhelmed with that this thing. But slight correction. I don't know where you got my biodata. I just now remembered I forgot to send you the short biodata.
Yeah, ma'am.
Well, I think it's from JSS. Corrections. It is 11 PhDs, and I'm no more a member of ISAC India chapter because it was a institution membership. So once I left Aish, I could not continue with that. I still have links with my colleagues in special education who are members of ISAC India chapter as well as ISAC main branch. So I do get the news, but that's all. Thank you anyway, Sanjana. Thank you so much.
Yes, ma'am.
I'll just minimize the video because I don't feel comfortable seeing my old face now on the video, and I'll only go for slide share. I don't know why this is. Just give me a second.
Yes, ma'am.
Initially, when I proposed the topic, I think I gave a topic title saying augmentative strategies in speech language. And when I was preparing these slides, I realized it's too vast an area to address with specific speech language disorders. So I'm restricting this talk only to aided communication. I'm not touching upon anything related to unaided communication. Those of you who have worked in AAC field do realize that in AAC, you typically have two options to work with: aided communication sets and systems, or you work with unaided. So this particular talk of mine will be restricted only to aided communication. And why I thought so was because I think amongst the audience, those who are really working in AAC field will be the ones who will be listening to this talk. And if there's, I don't even know how varied the audience is. And some of the vocabulary and some of the theme that I address will probably be best understood by those who practice AAC in their specific clinical setups. So with that introduction, let me move on. Now, when do we look for aided communication? This has been a question asked by so many of my young student clinicians, as well as debated across amongst professionals. There was a puristic view which said, let us first try speech therapy, and only when speech therapy fails, we'll start with AACs or augmentative communication. That is not true anymore. There's plenty of research pointing out to the fact that introducing or facilitating communication with all these strategies, augmentative strategies, definitely will not impair verbal communication. It will in fact improve verbal communication, and that has been my experience throughout when I was sort of leading the AAC special clinic when I was at Aish. And I've seen many children improving when AAC was introduced to them. So you always say that you start with aided communication when there's inadequate communication or there are communication deficits or poor speech output from an individual. But as I said, this is a thought that you should have, that it's not always true, or you can start off as early as possible. There's no holds bar to say that you wait for up to a certain age and then start this. Well, one yardstick that you can depend upon is how badly or how poorly the communication needs are met. How is it compromised? Is the child in a fix? He's so tied down that his communication is barred. He's not able to even address his basic needs. Hello?
Hello, ma'am. Sorry to interrupt, ma'am. Are you sharing your slides, ma'am?
I'm sharing.
Can you reshare it, ma'am?
One. I'm sorry, I didn't realize. Just hold on. Is it okay now?
Yes, ma'am. Yes, ma'am. Now it is visible.
Is it okay?
Yes, ma'am.
So I was just saying that in those instances where communication needs a compromise, you have to think seriously about this. Now, there's also a typical bifurcation expressed by, in some textbooks at least, saying that when there's a language impairment in the expressive language or receptive language, as quotes there, one should consider. And there is also a sort of miscommunication, I would say, amongst young clinicians, saying that only when expressive language is impaired, you consider AAC. That is not correct. Actually, communication as a whole, you look for both in receptive and expressive language fields. For example, in children with intellectual disability, it is receptive as well as expressive. When you are looking at children with apraxia of speech, there it is mostly expressive, but still you use AAC. So there's no definite bifurcation or line to say that you have to divide them like that. But in textbook, you do find this division. Now, I want to address this next issue that I am posing, that is AAC. In some meetings, in my interaction with youngsters as well as a little older persons, I've always seen that there's a confusion when they use AAC. The first A stands for what and second A stands for what. And unknowingly, maybe some of them use it as alternative and augmentative. My request is please do not do that, because there's a technical reason and a literary reason for not doing that. For example, when you're talking of augmentative, it just means you support the existing system of communication. It could still be a verbal component like a vocalization used to say yes, no, or a gesture such as a head nod. But you try to augment the existing communication chain that already exists in a child before you look for alternative. So that is the yardstick, and that's the reason why across the globe, you always refer to AAC as augmentative and alternative communication, and not really as alternative and augmentative. Now, in aided communication, you all know that it can be a very simple device, like in a communication board that most often use, and it goes to a very high end, that is a sophisticated assistive technology that we typically call as AT. And nowadays in market, there are many types of ATs, one with voice output or one with synthesized speech, etc., etc. There's no end to it. Now, when I talk about augmentative communication, I'm addressing all the issues related, starting from communication board or to a high-end technology that one may use. All said and done, one should realize that when you're looking at AAC in general, or specifically augmentative communication, it cannot be a global model. It cannot be something that you advocate, you take up one strategy, one sort of a principle and advocate that to everyone. It is always tailor-made, because individuals' communication needs vary. And especially in India, just now I'm connecting with the previous lecture that Kia gave, multilingualism, bilingual inputs. All of these create a lot of complexity in the communication needs of a child. And that is why it is called as tailor-made. And if you reflect back, if anyone reads through the textbooks in AAC, you realize that there are very few models. Unlike in language or LD that Prema was talking about in the morning about models, you don't have very many models talking about rehab, but maybe one or two talking about assessment. So this itself tells you volumes that one, of course, it is an AAC compared to any other field. Second, it is difficult to pose. You can just have some guidelines, some generic principles, but it's very difficult to talk about models. And this, although EBT is practiced, although research is in advanced stage, there's generally lack of sort of not very many case studies of clinical outputs coming up in this regard. So we still have to believe that we have to be tailor-made, think of tailor-made approaches to individuals. So although I named this as AAC communication strategies, let me make clear. Sanjana, can you hear me, Sanjana?
Yes, ma'am. You're audible, ma'am.
Okay. My PowerPoint is not shifting. I seem to have some problem. Okay.
It is changing, ma'am.
It changed now. Although mentioned as strategies, my intention is in this talk is not to talk about specific strategies, because there are so many that it would be impossible for anyone to address these strategies in a single lecture series like such as this. So I will restrict myself to general guidelines, so sort of what needs to be done in order when you select a strategy. What are your basic principles that you look at when you select strategy? And when I take examples, I'll restrict myself here once again to developmental disabilities such as cerebral palsy or children with intellectual disability or autism, etc. I'll give examples as and when I feel there is a need to it. But I will not be addressing the issues related to acquired disabilities like in aphasias and others, because it really widens the scope and I may not have the time to cover up all this. Now, I want you to look at this. I've put dividing lines simply because I feel many clinicians across India, they are confused when they look at it. On the left-hand side, to some extent, they know what device they'll be using. The device, as I already said, can be as simple as a communication board, or if they have one in a school setup, they prefer using the assistive technology device there. And nowadays, there are so many downloadable free apps available on AAC, which generally people download. And let me tell you, they are mostly restricted in their linguistic structure, but in any case, something is available. It's not that it's not at all available. And when it comes to symbols, one needs to understand that is what you put on a communication board or what you load onto a screen, which you want the child to learn. You should be knowing that there are symbol sets. Now, for example, PCS is talked about extensively, that is picture communication system. Now, what happens is this is a set because the expandability is limited. You can go up to a certain level of vocabulary building, but beyond the point, it cannot facilitate much advanced syntax, or it cannot give you scope to use new vocabulary, etc. There are limitations to that. So it's okay to use sets when you in beginners to start off with augmentative communication, but sooner or later you need to move on to symbol systems. Why? Because symbol systems enjoy this flexibility. They are more language specific this thing in terms of semantics, not only in terms of semantics, the syntax and the ability to expand the pragmatic aspects, etc. Now, examples, there are so many. I just take two examples here. When within this, they are classified in various ways. And when I say representational symbol systems, the examples would be glyph symbols and fixins that are talked of extensively in AAC, because they are. Hello. Hello.
Yes, ma'am.
Can I continue?
Yes, ma'am. Yes, please continue.
So glyph symbols and fixins are called as representational symbol systems simply because they represent an icon in glyph symbol represents a whole thought, a holistic thought. Similarly, there are some things called as symbolic language codes, and in India, it's preferable, or most of the clinicians prefer to use traditional orthography, because given the context of your bilingual exposure, etc., and the tool non-accessibility to specific APs or not being able to make communication boards, etc., traditional orthography has always stood as a support system. And there are many variants to it, and I'm sure some of the Pushpa, I can take the name of Pushpa. When she worked on a dissertation, we worked on a variant in traditional orthography, which is called as embellishment, enhancement, etc. There's plenty of literature on that. So what I want to emphasize here is when you're choosing as a therapist. Now, let me throw in the word AAC therapist. Now, we are not shying away with the use of AAC therapists, because worldwide, a person who specializes in AAC nowadays, the no holds barred. They call themselves AAC therapists because they are moving into that area. They may still work with speech language disorders, but using AAC as their modality, they prefer to be called as AAC therapists. So sometimes I might use the word AAC therapist here. So please bear with me. And vocabulary is something that most of them may comfortably choose depending on various issues, but this is a very, very crucial issue. There's a whole lot of issues to be addressed, but I'm not taking it up here in this particular presentation. Okay. And if you look at the third column there, you know that as clinicians, hello?
Yes, ma'am.
Hello? Okay. If you look at this and the last column there, in all these issues, that is, you select a device, symbols, and vocabulary. Ultimately, as a clinician, you're looking or reaching out to persons with spatial communication needs. Now, this is a type of jargon or a vocabulary or a notation that is used in AAC amongst people who practice AAC. It is preferable to call all the groups, irrespective of what core disorder that they have, whether it's apraxia or CP or other things, as persons who have complex communication needs or special communication needs. So that is the current trend to use the terminology. And you're not only looking at the person with this complex communication needs, you also need to address a lot of issues related to caregiver training, or it could be a family members training, and all types of communication partners cutting across teachers, or it could simply be a vendor on the street who wants to communicate, or the child wants to communicate with that person, etc. Now, we'll look at the central part of it. Now, this is a concern that I've had, or I feel with my experience, limited experience, it is called. Now, teaching and training in the use of these things, the device, the symbols, selecting the vocabulary, and putting them across to these children is where we need to think about in a very different way. Because you are serving speech language pathologists are often called as the leading members. AAC is practiced in a team. There are special educators, there are physiotherapists, there are occupational therapists, etc., etc. Depending on different setups, you have different combination of these team members. But SLPs always have stood and will continue, and this is literary support, also literature supports this. Now, speech language pathologists are placed higher. They are sort of team leaders in this, simply because you have a lot of scope to work on linguistic structures. You are a master in the linguistic part of it, the language component of it. So that is the reason why SLPs are equipped to train or teach better. And I would like to make them think how best they can do a need-based strategy selection and work on communication competence. So this is the ultimate goal. When you take up work with a child, you are improving the communication competence of the person in not really using a board, but the competence is what you look for. Now, what is this communication competence? From here afterwards, I'll be looking at only this aspect of it. Now, Light, who has worked extensively in this area, I take the quote from there, defines communication competence as the quality of being functionally adequate in daily communication or having sufficient knowledge, judgment, and skill to communicate. Now, how do we measure competence? This is something like somebody saying Manjula is competent, or so-and-so is not competent, or such a person is competent. It's very, what would you say, very individualistic. But there should be certain yardsticks to look at, and this is what I'm going to address. Now, there are many ways in which you look. I'll only be addressing a few of these. One is to look at the outcome measures. The outcome measures could be part of your EBP practice, or generically based on what controls you have in your clinical setup when you monitor, let's compare the baseline with the progress of a child, etc. with respect to the daily activities or the demands that are placed in the daily activities. Now, this is three-pronged. You not only look at outcome measures on the part of AAC user, but you have to look at the effect of these outcome measures, what is happening with the communication partners, and how the environmental factors are changing. Now, is the AAC user, that is a child with special needs, is the person able to control the environment? He can, is he saying switch off the light? Is he saying move away from the screen? Is he saying something like that? You know how well he is manipulating the environment around him using whatever training or whatever device that he's using now. Now, the second point that can be used as an yardstick is to look at adequacy of the package that he is using in meeting communication needs. Is it restricted only to familiar context, or is it extendable to unfamiliar context? This is a very crucial issue because so many children who come to clinics and who are trained at home, they may sail off well in the clinic setup, or they may even sail off well in the family setting at home. But when they are taken to some environment, say like a marriage function or just a party or a small get together in the family, it becomes an unfamiliar context, and how well the person shows his competence in expressing his communication needs. So you have to assess and find out or see what effect it has even in unfamiliar contexts. Now, skills to communicate. This is across. This is what the textbooks prescribe and talk about in typical augmented communication users. They define operational, strategic, social, and linguistic aspects. What does operational mean here? Now, operational is something which addresses how efficiently and independently an AAC user operates the AAC system. When I'm talking about AAC system, it can be anything, as I already highlighted. It can be a set or a system. It can be placed on a communication board or a computer monitor, etc., etc. So when you talk about strategic skills build up in order to improve competency, it is like looking at how well the AAC user uses compensatory strategies to communicate effectively despite restrictions imposed by AAC systems. Now let me just take an example here. Maybe a therapist is working, but the vocabulary or the single fire or something like that, and she doesn't have anything else. There's a matchbox, there's a fire picture on the board, but the child has been exposed to Diwali maybe a few days back, and he wants to talk about Diwali, he wants to talk about crackers, he wants to talk about sound, but there's no scope for him to either point out using direct selection technique or scanning because he's non-vocal, and the therapist has not provided a space on the board or the screen to add on, and he cannot on by himself. I'm using only male reference, please bear with me. He or she cannot by himself or himself cannot generate symbols. It's very difficult either because of motor limitations or sensory limitations, etc. in the AAC user. Now, how well the person transfers what he knows about fire to a concept such as the Diwali celebrations, where fire is also an important component. So that is something which we look at as strategic. And now social competence, it's more like pragmatics, verbal language. Now, how well AAC user uses pragmatic aspects of communication that knows that is, he knows when and what to communicate in different situations. Now, today, I'm not going to address all the three in greater detail, but I'm going to take up the next one, that is linguistic skill build-up of competence, because it is of direct concern to majority of the speech language pathologists. Now, what does it mean, first of all? It's a combination of so many aspects. It's like mastery of AAC system symbols or the symbol arrangements that are made, and effective acquisition of the ability to use the system for linguistic experience. Now, this has been a gray area, not only in terms of research, but in clinical aspects. Most of the clinicians are so concerned about this operational strategic social, but not too much thought is given about linguistic aspects. Both. So there is a limitation both in terms of the clinical and research angle as well. So I'm going to address this linguistic competence and give a few, think about a few principles which can be thought of to improve this linguistic competence in aided AS users. Now, skills in the native languages spoken in the family and community matters a lot. Just now we heard a beautiful lecture on multilingualism and bilingualism. Now, if this happens with typical children, imagine what is happening with a child where communication needs are so much compromised and he has so many limitations. Most are sensory, as I said. So many limitations. So, if it is a bilingual family, does he develop skills in the native language, or his skills are limited to native language? And how well are his skills taken up if a parent is also talking about a second language or speaking a second language in the family? There are so many issues. If linguistic competence is an important issue in typically developing children in bilingual environment or multilingual environment, is an important issue in India. Now in ASE, very little thought is given to this, aided ASE. So many times I've found clinicians who come from a different background. Maybe it's a Tamil clinician taking up a Kannada case. So obviously, he or she will not introduce Tamil, and he or she doesn't know much about Kannada. So what is the convenient method that they fall back on? They select English. Now, English is a new thing, and the family members may not be so well versed with spoken English, and they may not be using. Very little thought is given about this, and there are setups where even in school sometimes it is thrown onto the ASC users as a medium, where it becomes very difficult to match with the competence or see that the competence improves in an ASC user. Now, skills, the second issue is skills in the linguistic codes of ASC sects on the part of the clinician to master the linguistics. Now, it's easy to talk about a system like Bliss symbols, but if you note, Bliss symbols in its entirety is a huge language code. It is like learning any new language. There are so many rules to the system, Bliss symbol system, that unless you master as a therapist, if you're introducing this to an ASC user without any thought, it becomes very difficult. Now, Mechaton, so many times clinicians use Mechaton therapy. Fine, but one should understand Mechaton revolves around vocabulary. It's very useful up to a certain extent because it's a set. But beyond that, when you are introducing another one, the codes differ. So be careful when you choose different sets or systems and sort of migrate from one to another without giving a thought about that linguistic coding or the basics of what is happening within that set or the system. Now, there are few ways of looking at it or making attempts to improve the linguistic competence. And first of all, in ASD, one talks about improving the representational ability. Amongst this, there are various issues. I'll address the first one, that is, as an ASD therapist, you are supposed to improve the representational insight in the ASD child, ASD user. What do you do actually? You have to teach the relationship between the symbol and its reference. Now, most often, any teaching or any training that happens in ASD revolves around the reference. The reference would simply be a water bottle that's right now in front of me. Now, water bottle as a reference. What are the components to it? There are varieties of water bottle, and water bottle you can fill up with water, you can fill up with juice, you can fill up with any other liquid which is edible, maybe, or not non-edible. You can even fill petrol. So there are so many issues in there. Now, you have to, how well you train the child in understanding the relationship between symbol and its reference. Now, this depends on how well you create an environment to make the child learn the degree of iconicity that exists between the symbol and the reference. So you always have to start with a one-to-one iconic representation. You start with the thing which is very important. Now, if you're addressing, if you want to teach, say for example, a dog, and if the child has a pet dog at home, the photo of that dog is what you symbolize to indicate the reference dog. If you start at that stage and then move on in graded stages to a higher level of building up iconicity, it is much, much better. Now, this is very important in children with intellectual deficits because when they come to clinic, it's easy for clinicians to pick up something that's available on their table or the cupboard. Choose any dog's picture, give it to the child and train the child to think. But understand the difficulty that the child experiences in developing that representational sense, because he is a child with limitations and maybe the family has not exposed him too much to varieties of dogs, different types of dogs, small, young, old, different colors, different breeds, etc., etc. And he's only seen something that is there in the house. So for them to generalize this representation to different setups becomes difficult. Not only that, there are pictures. There are people who advocate pictures. They start off with. It is said that you can start off with 3-dimensional pictures and then go to 2-dimensional. Yes, of course, the gradation is important, but always start with a photo which stands for a reference in the child's environment, in the context, so that the child understands. Now, next level that you think of is exposure to symbolic relationships. And for this, experience matters. Now, we talk about speech language stimulation. In typical children, there are so many aspects to it. Stimulating the child to understand the context, the environment, etc. What are the symbolic relations? Now, that's where I think I'll just have to pull in some examples of one of my students' thesis. Many in CT, there was a study done by Tija Balan and children with cerebral palsy and their mother. She analyzed the dyadic communication relationship between children, mother and the child dyadic communication. Children suffering from cerebral palsy. And there's also plenty of literature which points out that so many parents, especially with children with motor limitations, they get restricted in the type of sentences they use. They don't speak much. They don't talk about imagination things, or they don't extend beyond the current issues like, do you want food? Do you want to go to toilet? So that's not all about it. That's not something. Please understand the mind of the communication needs of the AIDS user and expose the child to more and more experiences so the child understands the symbolic relation. Now, if I go back to the same reference of dogs there. Now, symbolic relationship of a line drawing of a dog just relates to the pet dog that the child has. To come to an understanding of this, there's a lot of experience build-up sessions required with that particular child. The therapist and the caregivers have to go through that in very many ways. So build up the representational insight so that you are working on representational ability of the child. There's also something called as dual representation that you need to work on specifically with ADHD users. Teaching the transition in representation, I've already given an example here. Now, referent was for you to teach dog. You start with the object that is pet dog and then go back. I'm sure the arrows in a reverse. It just means to say the representation of a picture of a dog should have its background established in the object form as well to say that it is a reference. Now, a lot of effort needs to be put here instead of directly selecting and starting off the word with a dog and trying to put that or impose that on a communication board or a communication screen. It is better if the therapist works on this aspect of transition in representation. It stands for something now, dual representation. Let me look at it now. Dog, how many features do we address? The dog barks and the characteristic is bow bow. You are talking of the barking style. What does the dog do? Bark. Does the dog run? Yes. And look at the characteristics. I was also talking about a bottle now. Bottle with water, petrol, etc., etc. Now, there are dual representations. That is, one icon, one reference could have multiple implications. So this is the basis for your ASU training. Because so many times when you build up a communication books, we often advise the parents to build up a communication book. And in that book, there's one particular reference or icon used to indicate the vocabulary of drink. I'll come to that later. But in order for the child to understand this thing, he must understand the duality in the representation that's there in the reference. The third issue that is important is also to build up symbolic sensitivity in the child. What does it mean? That is extendability, trying to understand the symbolic relationship between entities. If milk is introduced as a vocabulary, milk is also a component in coffee, in ice cream, and holistically it belongs to the category of drinks. So this is where I was just talking about communication boards with indices tagged on to the book. So it's something like teaching part-whole relationship and whole-part relationship to the ASU user. Now, symbolic sensitivity, you can start off with an early training also. Now, when you talk about the development of symbolization or symbolic growth in a child, developmentally, there are in typical children also it's observed that there are pre-symbolic behaviors in a child which is acquired much before the symbolic behaviors. Now, example of pre-symbolic behaviors could be like primitive gestures or eye gaze. You know, the child looks at this or that, mother, or a toy. And very few young infants does that. So these are pre-symbolic behaviors. And symbolic behaviors can be basically classified as whether it's intentional or non-intentional, pre-intentional. So the gestures that the child uses, for example, pointing to an object that the child wants becomes an intentional symbolic gesture. Now, when you say intentional symbolic gesture, it is mostly the vocalization that happens. He does that as a symbolic gesture of indicating ma. Ma means mama. It could be a ma, or it could be papa, could be a ba. So the transition that happens from pre-intentional symbolic to the intentional symbolic is something that one has to work on or look at or assess even before coming to the aspect of addressing the symbolic sensitivity. There are a few concerns because majority of the times a clinician uses picture-based representation. Now look at it. Now when you're looking at a picture-based symbol or picture-based representations as reference on your communication board, you should know that there's always an input-output asymmetry. Now, as a clinician or as a parent, able parent without any visibility in them, the input that they would be providing is in the modality of speech. Like I'll take the Kannada example, which is my native language, Nai Tosu, Tosu. So this input is happening in a speech modality, and the instructions from the caregivers are being given in the auditory mode. But the output expected on the part of the child with communication restriction is to target a language behavior that is different, that is picture selection, the visual modality. Now, this is something which is going to be difficult in those children with severe compromised behaviors, like in intellectual disability, or even with autism with poor verbal output, etc., etc. It becomes very difficult for them to understand, and that leads to a lot of confusion. So these are concerns that are there. So now why I'm saying this is, most often as a technique, what AC therapists use is direct selection, that is pointing to a picture, variety of ways. It could be an aided pointing, etc., and or they fall back on scanning procedures. Is it this? Is it this? Is it this? Or they may have a sophisticated system where VOCA is used, that is voice output communication aid. So VOCA, if you take as an example, the output is words. It's coming in an auditory mode set by a machine. Because it's a synthesized speech output which is coming, which in no way matches that of the parent, neither the mother nor the father. It is somebody's foreign. And often in India, we have the habit of taking up APs, which we buy things from Western countries. So there's a foreign accent added to that. And it's very difficult for the child to understand or match the input that's coming from the parent with that of the output. So I hope you understand what I'm trying to touch upon. This asymmetry should be addressed. It should be made lesser and lesser, and the impact should be reduced. And if you look at pictorial comprehension, now comprehension of pictures is an acquired skill. It is developmental in nature. Now teaching to equate pictures, which is a representation form, to the real life counterparts, that is real life experience or world knowledge in a child, is very, very important. In typical children, it happens so naturally because they are exposed to speech. They have enough sensory motor exposure, and their lifetime experiences of world knowledge improves with a lot of exposure to such things. Now, pictures can also be used differently with different purposes. Do you use it only for recognition? That is to recognize the similarity between two stimuli. As I already said, matching the photo of a dog with light drawing of a dog, just to recognize. Or make the child comprehend, that is understand the picture-based representation. That is associate the concept of dog with picture or photo. That's very important. Usability or use of the picture. Use information from picture to direct some action. Dog is one type of animal, as I said, as an index of animal category. So it is essential that the AAC therapist works on these issues in graded stages. It should not get limited only to work on recognition, but one should aim to work on comprehension as well as usability. It's always wise to touch upon or end up with the use. Now, if I'll just give you an example. A child is shown a picture of dog, but maybe he saw a TV show where an elephant was seen. And unfortunately, there's no representation in terms of picture on the board. Now, how good a clinician is in eliciting this? The child is very unhappy when the clinician goes on eliciting or talking about dog. He wants to say something about elephant. How does one do? This is what we call a communication chain, or how an efficient clinician does that. You can always, if there's no picture on that, fine. You can always fall back on a system of yes/no questions. Ask the child, is it dog? The child's first level team is saying no. Is it something else? Yes. Is it something within the animal category? Yes. So this happens with those with good receptive language, with good intellectual abilities. And this needs to be addressed quite adequately in when you look at picture representation. The next issue that I'm going to talk about is iconicity. What is iconicity? Iconicity is a multidimensional phenomena influenced by elements such as shapes, color, size, and complexity, how well it matches with that of the reference. And let me tell you, research on human visual perception has sort of said that object recognition relies more on shape rather than other perceptual features. Now, so many times we think color may be an important attribute, size may be an important attribute. Now we understand that more than this, the shape may be more important. So maybe in your buffer, you should think about improving the iconicity for shape first and then move on to color and size. Now, the concept of semantic compaction is sort of used extensively by promoters or marketing agents who promote assistive technology. They say there's such a high degree of semantic compaction in this particular machine, in this particular device. What does it mean? Semantic compaction simply means that there's a multi-meaning option or polysemic option of iconic encoding in which sequences of icons are combined in order to form a word or a phrase, and it's all a rule-driven, with a rule-driven pattern. Let me give you an example. Because in aided AAC, we do not use something like in verbal language. You are not very specific about using the pakka syntax, that is making a complete sentence with subject, object, verb, whatever order that you are looking for in that particular language. Maybe in that system or device, there's an icon for eye, there's an icon for an animal category, and there's an icon for sound. Let us look at these three icons that are seen. And if the intent of the child is to say, I saw many dogs barking. Now, saw, he would definitely point out to the eye icon, and the dogs, maybe he would select the animal page and then point to dogs. And for barking, maybe some sound, he might point out to dog and then sound. So one can understand that it is the dog's barking that he is looking. But what you may be missing out is many, because the word or the sentence that I said is, I saw many dogs barking. Where does the many come here? So in 18, it is possible to do that because bonded morphemes such as ES and S, if you're using English as a base, is shown there. So one points to that S. So one knows that he's indicating, the child is indicating that it has many dogs and not one dog that he or she is meaning. So this is all about semantic compaction. And if you have such facilities, even on your simple communication board, it is like working on a higher level of representation in your child. Now, there are other factors of concern also in aided communication. Now, symbol arrangement is an important issue. And always as a mentor or supervisor, I have pointed out this to some of the young clinicians. There are two biases in your visual field mapping, that is left-right bias or central-peripheral bias. Now, in these children who are compromised in terms of their communication needs, irrespective of the child, there's often a tendency on the part of clinicians to just go for left-right, because that is how you have grown up, and putting the symbols or putting the reading material, whatever, in left-right bias. But understand there are languages such as Urdu and Arabic. Maybe a child comes from that family background and that's the language is exposed to, and maybe he's seen a grandfather reading Quran in the different way. So it matters a lot when you are looking at the visual field. So be careful about these biases. Now, central peripheral bias, cerebral palsy children, I would like to take that as an example. It is very common to find cerebral palsy children having associated problems or comorbid disorders of visual field. You know, they have tubular vision, or they may see better in the center rather than the periphery. So it's important on the part of the AAC therapist to see where exactly to place the symbol, in the right upper corner or right lower corner, in the center, etc., etc. So this assessment is very essential on the part of the clinician before you really place the symbol to look at the visual field biases. The next issue is organization of symbols within pages of a display. This comes when you are using charts, multiple charts or layers of communication boards in a child with a little advanced listening. Row column scanning, for example, all of you have heard that, those who practice AAC know about this. If there's a particular icon present in third row, fourth column, the therapist resorts to pointing to the row first and gets a yes nod when the finger of the therapist moves on to third row, and then follows a column scanning. And in the column scanning, when the therapist reaches the fourth column, the child indicates yes. So the icon is present there. So this is done, but too many rows, too many columns can jeopardize the communication. So you have to be careful what you exactly do there. And some clinicians, this is a good system for thinking as well. Depending on the preferences or the use of the AAC user, they prefer to place a highly frequently used or highly preferred icon by a AAC user on the top or in the left-hand corner or in the right-hand corner. This is fine because I had one autistic type who was very fond of edibles or the kurkures and the other things. So the first thing that you do with a communication board, every time his hand used to point out to that. So you know the preferences before you place the symbols on the display. Now, sometimes symbols can also follow the word class category. All nouns are clustered on the left side. The middle consists of all the verbs, etc. Now, if you're working on building up literary skills, reading skills in a given child, and you're slowly progressing in that direction, or even if you want to introduce Fitzgerald-Key to improve the syntax level of the child, this would be a wiser thing to do. World-class categories are good enough, but it has to be taken up with proper judgment. Sorry. Now, color and contrast. This plays a very important role in early development of visual processing. And since AAC use or AAC user or AAC modality as such is highly visually oriented, the visual processing becomes very important. Now, it is said in research that colors are initially used to segment the visual scene and later to facilitate imagery trial. This is from a little older children and adults. So you be aware of this. So for what purpose color is being used? And this is the reason why this is a highly debated topic as well in aided AAC. Color and contrast enhances long-term visual memory. And for this reason, when PIC was proposed, that is pictogram, ideogram communication system was proposed, the symbols were placed on a black background. It looks a little, how do you say, it throws up on you, but this was the reason, and a lot of research went into that. Whereas on the other hand, the PCS, picture communication symbols, are simply placed as line drawings on a white background. So this particular area is doesn't have a conclusion. You don't find conclusive evidences or conclusive remarks, but you should be aware of this aspect. And it is also said the next aspect is the symmetry and axial orientation matters. Now, symmetry means the structure of a stimulus, how well it's a mirror image of the same, that is left and right should match. Now, in AAC, there are also systems which are sign-based symbols, like for example, 6 signs, where we talk about world signs. These are some of the sets that are used in AAC, aided AAC. Now, how well symmetry is represented, and For example, sign languages, your typical sign languages used with hearing impaired. You have symmetry as one yard. When both the hands are used simultaneously, the same hand shape, orientation, location, and movement. For example, these are the characteristics of a sign language. Hello?
Yes, ma'am.
So that becomes very important. Now, symmetrical. It is said symmetrical symbols are much better and should be introduced much earlier compared to asymmetrical symbols. Yet again, there's not much of research evidence coming to augmentative communication. Now, axial orientation, how it is aligned. Is it aligned? Are the symbols aligned in a vertical order or a horizontal order? Matters a lot. Here again, I don't have definite information, but axial orientation, it is said that vertical orientations are much better. That is, if you align one below the other, it is easy for the user to sort of point or to select. Compared to something which goes horizontal. I really don't know much about this. I don't have hardcore evidences in terms of research. But there are issues related to this. That's what I want to put across here in this particular slide. The next aspect is viewing perspective of the representation. Now, how many items are you putting as an array in the communication board or on the communication screen? The task becomes more complex as the array size increases. There are clinicians who restrict to 10, sometimes go up to 50, and I've even seen communication charts being prepared with hundreds. The more you crush in there, the more complex it becomes for the child because the size of the symbol reduces, so the representation really gets compromised. But of course, it is an individual choice, and it depends on the cognitive level of the child, and it also depends on the demands that are there in building up the communication chain and the type of communication system that you use, whether you're using a direct selection method or a scanning procedure, etc., etc. It depends on all these things. And next important issue is grid or schematic array of the symbols. A lot of research has gone into this. When you say grid array, it just means to say placing the symbol in a particular grid, like in a square or a rectangle that is available or divided on a communication screen or a communication board. This is what we often do with beginners. When you talk about schematic array, it just means that the theme of the vocabulary of the symbols that you are putting in there is important. Now, if you are addressing a theme like park, the symbols would be like icons would represent swing, seesaw, ball, etc., etc. So all related to a theme. And research has indicated that schematic array has its advantages with autistic children. They are much better off with schematic array compared to the grid arrays that are there. Now, whereas children with intellectual deficits, probably it's much better to start off with grid array, and depending on the degree of disability, it's also probably wiser to remain within the grid array. Instructions given to the AAC user also matters a lot. What is the nature of instruction that the caregiver or the AAC therapist is giving, the content part of it, and the intensity with which it is delivered. These are very important attributes when you talk about caregiver training, etc. I will not go much into depth here because it's a different aspect by itself and my lecture gets extended. I don't want that to happen now because it's late evening and I'm sure people who are listening also want to get off this particular topic. Okay, so nature, content and intensity with which the instructions are given matters. I'll come to the last slide here. All said and done, I started with talking about linguistic competence, and I highlighted a few factors which might help in building up the representational part so that the communication chain and the communication competence of the AAC user improves. Well, all this are fine, but there are very many intrinsic factors and extrinsic factors which may affect this. Now, intrinsic, of course, the age of the person, the child, the sensory abilities, cognitive, communication and language abilities. Now, let me show you. This terminology used in AAC is called something called as inner language, highly debatable. What is this inner language? It's like saying that we know that the child knows, but there's no way of casting how well the child knows, what he knows, etc. So even there's a lot of vagueness, so I don't want to highlight on that aspect. Communication as a whole and the language abilities, the receptive language abilities of the child matters. And then neurological and neuromotor status, whether it's a progressive disorder or a static disorder, and how well the motor abilities are intact or compromised, that matters. And motivation, generally the motivation on the part of the family, the caregivers, and the child himself matters a lot. Now, extensive factors, there are so many. And in India, I think this is the area which is very, very challenging for the AAC therapists. Characteristics of partners. Let me share my experience. Often, when a child is referred to the AAC clinic, the parent has come with a complaint saying that, no, this is not right. And they realize that something different is being done, not being taught or emphasized on verbal. The first objection that comes from the parent is, no, teach speech to the child. I don't want my child to learn to gesture or to point out to a board or depend on something else. But what they don't realize, because in terms of research also it's established, as I already said, that augmentative strategies do not hamper acquisition of verbal skills. In fact, research has pointed out that it facilitates speech output, and I've personally seen this happening in many of my cases. The nature of environment, whether the person comes from a rural background or urban background, matters a lot. Now, AAC tool and AT that is available in hand to the clinician or in the setup. Now, in India, this is again a very challenging aspect because I'm not a promoter. Please don't misunderstand me. But as I understand, AWAS, the assistive technology device that is being that is available in India at not higher price. I think it was 3 years ago, 5,000. I really don't know what it is now. It is good enough. It is comparable to the most advanced ATs that are produced in Western countries. So one should be aware of that and should really be in a position to advocate that. And AAC method that you choose. Do you use a combination of direct selection or scanning or any other things that are available, or what type of scanning, what type of direct selection? All these are extensive factors which have an influence on building up the communication chain in our child. And language task. Now, I just want to quote my experience in this. I know in one of the autistic child, I don't want to name the child, and I'm not so sure whether the person who worked as a clinician then with the child, so if he or she is participating here would recognize this. We were working, we presumed that the child's abilities are lesser. So started off on a yes-no communication chain. We wanted him to learn to communicate by saying yes or no or indicate yes or no to multiple means for the vocabulary that was good. And we realized after a few sessions that the child was mumbling. The clinician came up and told me, "Madam, something is happening. He is continuously mumbling." And the mother who was so close to him throughout had also ignored this. We wanted to know what it was. And when closely observed, in fact, it was verbalization. Verbalization of saying things like, I don't want this book. I don't want to come to therapy. Or negative, of course, but positive for edible things because he was a person who liked chocolates and things like that. So when we realized that, we put him onto a computer-based system, and it was like this. But there was an instant growth in his language use and communication chain. And I always remember this as a lesson that I've learned in my life. Don't have assumptions. There are children who can have higher communication abilities, but don't presume that it is lower in some children. The next is characteristics of the array. That is, as I already said, it can be a schematic or a grid array, but make sure that it represents the real world and not doesn't look artificial. Don't make cutouts from advertisements and put them there, because a pizza which is not used at home doesn't really give a world knowledge to the child. To be aware of this, and the instruction method that is used is very, very important. And to summarize, in the Indian context, I'm just looking at the extrinsic factors, which are very many and challenging. To an extent, probably you can control the intrinsic factors, but not really the extrinsic factors. You can solve this out with counseling, proper interaction with the caregiver and the groups of trainers who are involved. And you need to take a critical and analytical approach, even if it happens to be a case-by-case instance. Now, that is where we lack. The evidences in AAC therapy, it's very poor in terms of record maintenance or case studies being put up, depicting the sequence of growth that has happened in a given communication user communication, but AAC communication. Well, with this, I would like to end my talk, and then I think I extended my time. I'm not so sure, Sanjana.
Yes,
Sanjana, have I
yes,
extended?
yes, ma'am.
15 minutes, I think, no? Okay.
That's
I
okay,
don't know
ma'am.
when I started, so I really don't know.
That's okay, ma'am. That's okay, ma'am.
I would like to end this talk with my thanks to Dr. Nachraj, who has been my teacher, my mentor, and guide. And I've worked in Jesus. I'm still there, attached in many ways. And it's very nice to get associated in such talks. And a special thanks to Narasimhan, Sanjana, and Saransh too, because I heard his voice. Thank you so much.
Thank you, ma'am. It was indeed a very fruitful and informative session, and the experiences you shared added more meaning to your presentation, ma'am.
Thank you so much.
The participants have posted a few questions, ma'am. If you permit, can we take one or two questions, ma'am?
Sure.
The first question is, ma'am, can AAC and speech training be done together as multimodal communication therapy?
It should.
Yes.
It should be done.
Yeah.
Because, as I said, research has never pointed to detrimental effects of the interaction of modalities. Irrespective of the modalities that you use in AAC, the verbal output, the verbal modality has improved, and there's plenty of research support for this. So it should be done and start off from an early age itself.
Yes.
But of course, I didn't share the research papers. I've not cited the references, but if somebody's interested, I can get back.
Yes, ma'am. There's another question, ma'am. What can be done if the individual can't use his or her hands to touch the AAC device?
There are plenty of methods, like you simply use what do we call as pointers. There are many improvised versions of pointers. If it's a poor child and if you don't have very many, you can simply use a scale. Select a scale, wooden scale, make some modifications to the scale so it and tie it around the wrist of the child, not too hard. The pointers are available, mechanical pointers you can make on your own. And that's what I said, don't try to order them from the market. It's not available in India, it's not going to be possible. You think of developing your own and doing such things. It should be done. I think the question was motor issues in the hand that is being pointed. Now, one other aspect that the clinician can look for is if the motor abilities of hands are compromised, see if there's a head mobility is better off so that the head pointers can be used. Or even seen in cerebral palsy institutions where foot pointers are used. So think of different options there. Hello?
Yes, ma'am. Yes, ma'am. Next question we have, ma'am. is what is the correct age to start with AAC and speech therapy as it is followed in other countries? By including both the strategies, will it deteriorate the development of verbal communication because the child finds using AAC is easier?
First of all, two aspects I'll touch upon. The question says, like done in other countries. I'm not so sure. Why should we follow the model of other countries? First of all, that. And I already answered that in the first question. There's no harm in introducing AC methods. Now let me go back. Now, so many times we did a small observatory video, or I think it was a study. I'm not so sure about it. It was a small video of a Down syndrome child trying to communicate to the parent using a lot of gestural components in his communication chains, which was totally ignored by the clinician as well as the caregiver to such an extent that there was a communication breakdown. So don't ever do that. The point is always try to establish the communication chain. Use all modalities. If you observe a child very closely, you will definitely find that the child is using one or the other modality. Even a very severely impaired child will have one or the other modality. It could be a simple smile. It could be something like eyes rolling towards the stimulus. Things like that. Observation is very important. One, rest assured, there's no harm in introducing. Age depends on when is the child visiting you. If you're making a home visit after a newborn screening, start off early. There's no harm. I also tell you that when I lecture, and that's why I minimize my video, I use a lot of pose gestures. Many of us, to make a point or to emphasize a particular aspect in my speech, I would have used pose gestures. If adults are permitted to use that, why not children? Why are you restricting the children in doing so? That's, I hope I've answered the question. I'm not so sure.
Yes, ma'am. Can we take up another question, ma'am?
For sure. I have no restriction. I'm still at home.
Yes.
But participants may want to, I don't know. It depends on your organizer's decision.
I think we can take one more, ma'am.
Yeah, sure.
Can AAC be included in early intervention therapy for both verbal and non-verbal autistic children for providing different modes of communication?
Definitely yes, because one thing in my clinical experience that I've gathered is the success rate I'm talking about that I've seen with my experience with autistic children, and I think other clinicians who practice may also say yes to this, has been much higher. They really respond, and it's very, very good results that you see with autistic. But it depends on what are the comorbid conditions that are there in the autistic child. It's very important to recognize that.
Yes, ma'am. Ma'am, I think we are running short of time and we are left with 4 more questions. If you permit us, can we please mail the questions back to you, ma'am?
Definitely. I will answer.
Yes, ma'am.
Send it to the mail, I will answer.
Yes, ma'am. Thank you.
Thank you so much, sir, Sanjana.
Thank
Thank you so much for this opportunity.
I must thank you for accepting the invitation and being a part of this webinar. It was really informative, at least to me, and I'm sure you have stimulated many young professionals to at least think about it. Thank you very much.
Thank you so much, sir. Thank you so much for the opportunity also. Thank you.
So my screen sharing is paused.
Is it?
Yes, sir.
No, your screen, it is showing Sanjana Singh is started sharing the screen. From my side, it is permitted, Sanjana. Shall I? Your screen is visible, Sanjana.
But I'm not able to load the PPT, sir. Just a second. Yes, sir.
Yeah.
Yes, sir. Ma'am, I request you to kindly accept the letter of appreciation for being a resource person in today's webinar, ma'am.
I think
Ma'am is
ma'am
there?
lost the connection, Sanjana.
Oh, okay, sir. We will mail it to ma'am then.
Yeah, please.
Yes, sir. And this is a kind note to the participants that tomorrow we have 3 sessions scheduled. The first 2 sessions are in the morning, one between 10 to 11 and the second one between 11 to 12. And the third session is between 4 to 5. So I kindly request you all to make it convenient to attend the session scheduled for tomorrow's webinar. And also note, in the chat box, there is a link provided. Kindly fill in the feedback form for the sessions which were organized today. And you may please use the same Zoom link to join tomorrow's sessions also.
Thank you, Hiya, ma'am. I can see ma'am is here. Thank you, ma'am. Thank you for accepting
you,
our
ma'am.
invitation and joining this webinar and sharing your resourceful knowledge.
Absolutely. Thank you very much. It was wonderful. You did a wonderful job organizing and moderating, and I really am grateful for the opportunity to all of you and Dr. Nataraja. Thank you.
Thank you, Dr. Yadath. Yeah,
All right.
we will continue to be, continue
you.
to work together. Thank you very much.
Thank
All
you,
the best.
sir. Thank you.
All
Take
the
care.
best. Thank you. Thank you.
Bye.
Thank you, ma'am. Thank you. Bye.
Bye.
Thank you, ma'am.
So, sir, with your permission, can we close the meeting, sir?
Yeah, please. Please.
Thank you. Thank you, sir.